Now let's look at your drug regulations. So where did all this come from? Um, in 1906, the Pure Food and Drug Act was the first federal legislation in the United States, and it was aimed at protecting us from anything that was mislabeled, anything that was not something that was going to be good for us. It could poison us. It could harm us. It wasn't the right dosages. So they started realizing that maybe we need to put a regulation on this. So, Food, Drug, and Cosmetic Act in 1938. It was also amended in 52 and 62. So it added several provisions. So required drug makers have to label their products, indicating whether they contain potentially habit-forming substances, and to include warning about possible side effects. So the things that we know could happen. Authorized the creation of the FDA, which we'll discuss later in the chapter, and then mandated that dangerous drugs could be dispensed only with a prescription from a physician, dentist, or veterinarian. The Harrison's Narcotic Act of 1914 regulated the import, manufacture, prescription, and sale of several non-narcotic drugs and cocaine, opium, and their derivatives. So precise record keeping about the dispensing of controlled drugs and registration of distributors, such as pharmacists, are required. Penalties, namely fines and imprisonments, are specified for illegal possession or distribution of controlled substances. The Narcotic Control Act of 1956 increased the penalties for violation of the Harrison Act, made the possession of heroin illegal, and outlawed the acquisition and transportation of marijuana. In 1970, Congress enacted the Controlled Substances Act, comprehensive legislation dealing with narcotics and non-narcotic drugs that have potential for abuse. This act specifies requirement for registration, procurement, storage, distribution, and record keeping for these drugs. So this is where when we go in the morning, or your paramedic right now, because at the AEMT level we don't have narcotics, but this is why we have to go in. I have to count all of my medications. Yep, I have them all. I sign for them. The off-going shift signs for them. And then at the end of our shift, the oncoming crew will sign for them. So it's that chain of custody. We have to show that chain of custody for these narcotics, and this is where it comes from. With that, they came together and they put together 5 categories or schedules of abuse potential. So this is how the drug dependence that you may encounter with those particular drugs. We do not deal with Schedule 1 drugs. So our heroin, our marijuana, our LSD, not that we administer. We typically deal with it after they have already taken it, and now they're either on their high, coming off their high, or it's completely knocked them out and you're having to assist their ventilations. So, or it's killed them, unfortunately. So, figuring out, this is your Schedule 1's, your high abuse potential, no recognized medical purpose whatsoever. Your Schedule 2 drugs, your high abuse potential, legitimate medical purposes though. Your fentanyl, your Ritalin, your cocaine, medical cocaine. So these are the medications that we, at least the fentanyl we carry, that we can help alleviate some pain for our patients. And but realizing my patient may refuse. My patient may say, nope, I've had a drug problem. I cannot take fentanyl, or I cannot take narcotics. And this is where, let's go on down to our Schedule 3. Our less potential for abuse than Schedule 2 medications, our hydrocodone or our Vicodin, our acetaminophen with codeine, Tylenol 3 with codeine, and our ketamine. This is where our ketamine comes in as far as not being as addictive. It has a different action. but it will reduce their pain for that short period of time without knocking out their respiratory drive. Schedule 4 is less potential for abuse than Schedule 3 drugs. So this is our, think about this as our seizure meds. So our diazepam, our lorazepam, Valium, midazolam, our Versed, these medications that I may need for that patient to break their seizure or at least try. And then our Schedule 5, less potential for abuse than Schedule 4. So my Tessalon Pearls, my narcotic cough medicines, my cough syrup with codeine. So these are the ones that I can go in, I can get from my doctor. It's like, look, doc, I've been coughing, I've got this bronchitis, I got this pneumonia, I need something. And hopefully that helps. All right.